Good evening, everyone. First, let me introduce myself. My name is Samya, and I am a scientific content writer in Linux. I'll be the moderator for today's presentation, and I'm glad to welcome Mr. Jihir Kapoor, who will be present on comparing the average cost of outpatient care between public and for-profit private providers in India. Jihir Kapoor graduated from MIMS Bangalore. He worked as a management trainee at GTM and Sons Advisor Private Limited before this internship. His work at Renix involves collecting and analyzing the data regarding GDP, expenditure, healthcare, unemployment, etc. Without further delay, I request Jived to take over.
Good evening, everyone. So comparing the average cost of outpatient care of public and for-profit private providers in India. Original authors Sameer Garg, Narayan Tripathi, Alok Ranjan, and Kirti Kumar. Topic selected is health economics. Journal name BMC Health Services Research. Impact factor is 2.512. Year of publication 2021. Introduction. Understanding the cost of care associated with different kind of healthcare provider is necessary for informing the policy debates in mixed health systems. There's a shortage of such information in most low middle income countries. India has a mixed health system with a sizable private sector presence. There are three kind of providers: public providers, private for profit, formal providers, and informal providers. The formal and informal providers together account for 69.8% of India's outpatient care, the most common form of healthcare utilization. A few studies have compared the cost of public and private providers. These studies report the average cost of input consumed per episode of care, but they do not report the total cost of per episode of care. The out of the pocket expenditure OOPE incurred by the patient has not been considered. Another set of studies in India have focused on comparing the OOPE per episode of care in public and private facilities. However, such comparison may not portray a fair picture because they do not take into account the government subsidies received by the public facilities. Private and publicly funded health insurance is limited to inpatient care. For profit private facilities providing outpatient care in India thus have to cover all their input cost out of the payment they take from the patient. Present challenges. Poor regulation for profit providers seems to be an important structural cost driver in the mixed health system of LMIC or low middle income countries like India. Wrong decision in health system may cause public to shift to informal providers where they are not fully able to treat the patient and could put them in more danger. Objectives. This study is aimed to carry out a fair comparison between the average cost of acute outpatient care in different types of outpatient healthcare providers for a state in India. It aims to take into account all the direct cost borne by patient and government. This study also seeks to provide a comparison with informal private providers who constitute a significant part of the outpatient utilization in India, but have not received much attention in the recent studies of healthcare cost in India. Methodology. This study is conducted in Chhattisgarh. The state had a population of around 28 million in 2019, with 77 of it living in rural areas. This was a descriptive study. The study relied on two data sets: a survey utilization of outpatient care by household and individual, including the type of illness, type of provider utilized, and the out of the pocket expenditure. A large household survey on morbidity and utilization was carried out in Chhattisgarh in December 2019. Second, a survey of government health facilities to find their input cost. A survey of various kinds of government facilities was carried out in early 2020. So the health system of Chhattisgarh, like most of India, is organized in different tier. Sub health center at 3,000 to 5,000 population, a primary health center 20,000 to 30,000 population, a community health center at 80,000 to 120 population, district hospital around a million. The district hospital and the community health center provide secondary and primary care, whereas the PHC and the CHCs focus exclusively on primary care. All these facilities handle three different kind of function broadly: providing outpatient care, providing inpatient care, and third, non-clinical public health function. Then there are community health workers, looking at the average population around 350, who are paid by the government. For each 5 districts covered in the household survey, 1 DH, 3 CHCs, 4 PHCs, 5 CHCs, and 10 CHWs were selected randomly for this facility survey. Cross tabulation were used for descriptive of OOPE of different kinds of providers. Linear regression was performed to find the determinants of the size of the OOPE. The purpose of the study was to find out the total cost of resources used per episode of the outpatient care. For this purpose, both activity-based costing as well as the time-driven activity-based counting was used. Under ABC, the government was computed using the government expenditure was computed using the facility survey data on basic input, including recurring cost of human resources, drugs, consumable, etc. Cost of land was taken at the current open price, and the cost of capital items like land, building, equipment was annualized by using discount rate and expected lifespan. Costing was also carried out by using time-driven based costing. This method has been devised to overcome the limitation of ABC. It was found useful for finding a cost per patient in general healthcare situation, like in the current study. A process map was prepared for outpatient care. Based on the processes involved in the outpatient care, time equation were developed to find the minute of staff time required per outpatient episode. Cost per unit of practical staff capacity was used to calculate the total cost of per episode of outpatient care. So outpatient care handled by different types of provider. Among three types of provider, the public provider had the biggest share, followed closely by the informal private provider. The formal for-profit private sector had the smallest share in utilization. Among the public provider, CHW had a bigger share than others. Among the formal for-profit providers, private clinics accounted for the greatest share of utilization than the private hospital. Portion of different elements in outpatient care episode managed by different types of provider. The disease-wise breakup of FEP episode of acute outpatient care handled by the public and private providers. Typhoid was the only disease that formed a greater share in of former private sector utilization comparison to public providers. Result, all the diseases had a similar proportion in the disease profile of different providers. The linear regression performed for determining the size of the outpatient out of the pocket expenditure showed that an episode of outpatient care with formal provider was significantly likely to involve outpatient care of 2034 greater rupees greater than the public facilities. However, the regression showed that the OOPE for informal private provider was not significantly different from the public provider. Sensitivity analysis shows that the average cost in the public facilities was most sensitive to the volume of patients seen, followed by the human resources and the infrastructure cost. Discussion. A national survey in 2017-18 had a similar amount of OOPE in public facilities. A recent study of 3 states of India has reported the input cost of outpatient care as 183 rupees for DH and 134 for CHC. The current study found the above cost was higher in Chhattisgarh, rupees 305 for DH and 373 for CHC. Earlier study had found that the outpatient care constitute around 20% of the total hospital cost, whereas the share apportioned for the outpatient care in the current study was greater at 41.4% for DH and 36.5 for CHC. The current study found that current study found that among the public provider, primary care provider delivering care close to the community involved less cost than the secondary care provider. Earlier study in India have reported a similar pattern. This suggests that the organizing primary care close to where people live can help bringing down the cost of government and patient. Conclusion: the current study presents a fair comparison of average cost of care for public providers and for profit private providers. The average cost of government and household put together was substantially greater when formal for-profit providers were utilized than the public providers. Impact of the research. This has important policy implication for India's mixed health system, including the desired public and private mix, the appropriate role for for private sector. It suggests that purchasing from private providers or extending the publicly funded insurance to outpatient care in India may increase the cost. Limitation. There's a serious gap in existing literature considering the large share of informal providers command in outpatient care in India. There can be a valid concern regarding the quality of care provided by the informal provider given their lack of medical training. Thank you. Ma'am.
Sorry, I'm on the. Thank you very much, Zavir, for very informative talk, and I hope we all have learned a lot from this presentation. Now, Zavir will answer some questions that were sent us during the presentation. The first question is asked by Vijay. The question is, what are the reasons for higher cost in Chhattisgarh?
Uh, it's not mentioned in the paper, but it's related to the human resources and the cost of land different from the other states. Cost of land is different from other states. Three states that chosen in the previous studies may have cost of the land at different market rates. However, the cost of land in Chhattisgarh is at different states.
Our next question is from Nupur. What is meant by informal providers?
Informal providers, which they don't have the registered license to open a clinic, or they are providing medical facilities without the proper knowledge.
Are they authorized then if they are?
No, ma'am, they're not authorized. That's why they're informal, ma'am. So they are not allowed. Actually, they are not allowed to open up medical facilities. But many people that live close to that clinic, informal clinic, they tend to go there because of the lower cost.
Yeah, but how do then the researchers get data from these unauthorized establishments? Because it's difficult, no?
They had a survey, so ma'am, it's written. Do you go to a public facility? Do you go to a private facility, or do you go to an informal, a uh, local clinic? And I don't know if the survey actually questions is that because the patient do not know that the clinic is authorized or not.
Okay. And one more question: is there any difference between the costs in rural and urban area? Because Chhattisgarh,
it should be, ma'am, but this research paper has not focused on that.
Okay.
So, ma'am, that's why I don't know.
One more question. So the selection of healthcare providers, does it include only allopathic or alternative medicines are also included?
So what I have in that, so it's outpatient care, so I don't know what kind of medication it includes, but it's outpatient care only, and they're just comparing the outpatient care, and the disease wise breakdown, as you can see, was this. So I don't know what kind of medication they provide.
Okay.
Thank you again, Zubair, for answering those questions and for the great presentation.
Thank you, ma'am.
Lastly, before wrapping up the webinar, I would like to inform everyone that our next presentation will be held on 19th of August 2022 on targeting the alpha-V integrin and TGF-beta axis improves a natural killer cell function against glioblastoma stem cells by Soumya. Let's meet next week at the same time. It has been a pleasure having you all here. Have a pleasant evening.